Welcome everyone to the Kawasaki Disease webinar today. While you're all being let into the lobby, I'm just going to go over a few things. I am Kathy Olevsky, the webinar host for the Vasculitis Foundation Educational Webinar Series. I love doing these informative webinars as I'm also a patient living with MPA vasculitis. You know, there are over 20 forms of vasculitis, and until recently, I didn't know anything about Kawasaki disease. So I'm looking forward to learning with the rest of you today. And for today's webinar, we have three guests. Dr. Mark Gorelick will help us understand Kawasaki disease with his presentation. We also have two parents of children who have Kawasaki disease, Nancy Foster and Nicol Jackson. So welcome, Dr. Gorelick. Thanks for being here as our expert today.
Sure, thank you so much. So let me get started and just, as you said, share my screen so that we can talk a little bit about Kawasaki disease.
You're all set. We see it well.
All righty. So, so this presentation is going to be a brief discussion of, what is Kawasaki disease, and then also a little bit at the end, just because there were some questions about my own research in Kawasaki disease as well. So what is Kawasaki disease? Kawasaki disease is a vasculitis. And so what is a vasculitis? Vasculitis is an inflammation of blood vessels, kind of an itis of the vessels, as the name sort of suggests. And when blood vessels become inflamed, they can become occluded by the inflammation. They can become scarred, in which case they don't dilate properly. Blood flow through them can be decreased, and there can be abnormal blood flow. And so depending on where the blood vessels and the size of the blood vessels that are involved in the vasculitis, you will have various kinds of end organ damage or injury. So certain vasculitis are in medium-sized vessels, and involves, say, the kidney, the vessels that supply the kidney, and decreased blood flow. The kidney can change blood pressure. Small vessel vasculitis in the lungs can cause other injuries, and those are all different kinds of vasculitides. And Kawasaki disease falls under the medium vessel vasculitis family, which is also consists of polyarteritis nodosa, which is a pretty nowadays rare vasculitis. It was actually associated with hepatitis B, and it's become very rare since the advent of the hepatitis B vaccine, but there is still non-Hep B related vasculitis. And these are all the other kinds of vasculitides that can be seen, like Takayasu's and giant cell, as well as ankylosing, etc. So how do vasculitis happen? We don't understand that completely, but one thought is, and if you try to think of yourself from the perspective of a virus or a bacteria that's trying to get into an organism, the best way to do this is to disguise yourself to look like some parts of the organism, because you won't be able to be, or the chances of you being detected are less. But eventually, when you are detected, your immune system, which is a very efficient tool, but not the brightest tool in the world, will go on the attack and look for everything that looks like you, and that not only includes the virus or bacteria, but also the parts in your body that also are reminiscent of that. And that's sort of the molecular mimicry theory of autoimmune disease, and it seems to apply quite a bit to vasculitis per se. And so you will get injury to the blood vessels, which a lot of the organisms have tried to mimic. And so specifically in Kawasaki disease, the kinds of blood vessels that are involved lead to symptoms, physical findings that encompass a couple of different areas. One is rash, and that in part is likely due to the response of the body to the initial infectious process. Conjunctivitis, which also may be kind of similar to that. Redness and inflammation in the mouth and the tongue. And this is actually a true vasculitis. If you biopsy the mucous membranes of individuals with Kawasaki disease, they will have clear vasculitis of the vessels inside the mucous membrane. Swelling of the hands and feet and erythema of the hands and feet, which, we don't exactly understand why that happens, but it is likely both related to the vasculitis and the acute inflammation, and does happen in some other, very severe inflammatory diseases, including toxic shock and also multisystem inflammatory syndrome, which was related to COVID. And then finally, the blood vessels of the organ that are often associated most are the heart. You can get vasculitis of other vessels in Kawasaki disease, so it happens not infrequently that there are other vessels involved, such as vessels around the groin and vessels in the chest, but mainly the coronary arteries are the ones that are affected. And so this is just a picture, a textbook picture, well-known picture actually of a child with Kawasaki's, and this is the other feature of Kawasaki's is these children look sick, they look, very miserable, and it's one of the, although these are the 5 cardinal signs, another cardinal sign really, which is not in the guidelines, is just very ill appearance. So Kawasaki disease is the #1 cause of acquired heart disease in children. And that used to be actually rheumatic fever. But once we got a handle on strep and understood the relationship, we're able to treat that now. And so that is no longer the #1 cause, replaced by Kawasaki disease. And the way generally that we treat Kawasaki disease mostly is with something called immune globulin or IVIG. And the way that IVIG works is essentially, and we don't know completely how it works, but it floods the body with antibodies that appear to block the normal uptake of antibodies that are bound to various pathogenic or various autoimmune epitopes. And so by blocking that pathway, it suppresses the ongoing inflammation. Although, again, there's probably a lot more to that. And when you treat patients with Kawasaki disease, you go down from, of all patients who get Kawasaki disease, about 25% can get persistent vasculitis in the coronary arteries or persistent damage. And the treatment with IVIG cuts that down to about 5%. But that's still a fair number of children. And there are about 3,000 or so cases of Kawasaki disease a year in the United States. So IVIG although IVIG mostly works, there are cases where Kawasaki disease is what's called refractory or doesn't respond to the initial therapy. And that happens in about 10 to 20% of cases. And it mostly happens in patients who are at extremes of age, but it's also the very old or very young patients. And sometimes also patients who have already, severe disease at the onset. And when that happens, there are additional therapies that one can do, either repeat the IVIG, use a pulse steroid dose, or use biologic medication. And this is which one of these to choose is currently under investigation in various studies. There's also what's called incomplete Kawasaki disease, which is important to remember. So incomplete Kawasaki disease is when you have a patient that does not seem to manifest all of the symptoms of Kawasaki disease, and so it can be very tricky. Patients may have 1 or 2 of these 5 cardinal signs that we talked about. So, really ideally, we want to see all 4 or 5 of these cardinal signs, having conjunctivitis, red hands and feet, the mucous membrane changes, and rash. But in some cases, you might only get 1 or 2 of these. And that can be difficult for the diagnostic physician because you don't know whether you're just dealing with fever or rash or not. And it tends to be that the rate of incomplete Kawasaki disease is higher in kids who are young, very young, under 6 months of age. And in some cases, there have been some studies that have suggested that patients who are little infants who are under 6 months of age might only have prolonged fever and then are subsequently found to have coronary aneurysms, suggesting that they did have Kawasaki disease, even though they had none of the other features. And so prolonged fever is one of the reasons to get an echocardiogram in a young infant, 6 months of age. So another form of Kawasaki disease is called Kawasaki shock syndrome. And this is a kind of an atypical feature. It's about 5 or 10% of all the Kawasaki disease patients. And in these patients, they tend to get shock. In other words, they come in with low blood pressures and some of the features of Kawasaki disease. And it actually is very reminiscent of multisystem inflammatory syndrome, and led us to believe that these two diseases, the multisystem inflammatory syndrome and Kawasaki disease, were related. So this is just a little bit of the pathology that happens with Kawasaki disease, and it's something to understand a little bit more of what the vasculitis means. So these are the normal blood vessels, and a normal blood vessel has 3 layers, what's called the intima, the media, and the adventitia. And when Kawasaki disease begins, the blood cells invade the walls of the blood vessels, and you get this destruction. And following that destruction by these neutrophils, which damage the blood vessel wall, which usually happens in about the first 1 or to 10 days of the disease, you then get what's called proliferation inside the blood vessels. So these would be normal-sized blood vessels in which sort of an attempt at healing takes place, and you can see that sometimes they can become all the way occluded or blocked. And in that case, it can be very catastrophic or dangerous, because blocking of a blood vessel in the heart obviously can cause equivalent of a heart attack in a child. So a little bit about what's new in Kawasaki disease research and in the clinical world. One thing that's new is the recent ACR Vasculitis Foundation guidelines. There have been pre-existing guidelines for Kawasaki disease that are excellent and have been done for years by the American Heart Association. But for some more complex cases where rheumatologists might see these patients, there were some additional recommendations. And some of these additional recommendations are based on recent research. So one of those recommendations is that for patients that appear to be higher risk, and that's a difficult question because we don't know exactly how to define high risk, but one thing that we do know is that patients who are, again, very young at extreme of age, so under 6 months, or patients who have already presented with aneurysms in the first 7 to 10 days when they are first seen, are more at higher risk of either being refractory or having aneurysms that don't want to go away. Those patients can get a dose of steroids with their IVIG and a sort of a course of steroids over 10 to 15 days. And that it apparently, and there's still some studies going on, but appears to decrease the rate of aneurysms down the line. So secondly is, we talked about the refractory Kawasaki disease, where you might need a repeat dose of IVIG. And that in our guidelines has been sort of validated as an okay thing to do, but sometimes in some people, repeat doses of IVIG can lead to transient breaking down of red blood cells by an immune mechanism. And so in some patients, use of other kinds of repeat or secondary line therapies is more recommended. Third is use of high dose aspirin. So it has been very much part of tradition that when patients with Kawasaki disease are first diagnosed, they're started on very high dose aspirin. And that's sort of a holdover from the very, very, and I should say I'm getting up there too. So the ancient days when Kawasaki went before IVIG, and in those days, the only therapy was aspirin. So high dose of aspirin were used, but there's really no evidence that high or low dose of aspirin, there's no difference between that dose choice, although using aspirin of some dose is important. So the guidelines suggest that any dose, whether it is low or high, could be used. IVIG remains the central tool for Kawasaki disease in our guidelines. And then, as I mentioned, in the refractory cases, using biologic therapies can be used. In terms of long-term issues, which is sort of really the big question that parents have, what are the long-term issues after Kawasaki disease? Patients who have had Kawasaki disease and have had no aneurysms or even small aneurysms that have resolved generally don't show any greater risk than a general population for long-term bad outcomes later in life. But patients who do have large aneurysms do have a higher risk of long-term adverse cardiac events as they grow up because those changes in the blood vessels of size and cause clotting, and that can lead to problems, and that's why those patients need to be followed closely and be on anticoagulation therapy. And then finally, in some patients who get joint pain and arthritis, those patients tend to have limited, really self-limited joint pain and arthritis. And so if that is persistent, if a patient has joint pain for many, many months after Kawasaki disease, it may be that the initial diagnosis of Kawasaki disease were wrong, because Kawasaki disease really is a self-limited disease. It's acute, and that makes it different to other vasculitis syndromes for the most part, which are chronic diseases which require chronic therapy. Kawasaki disease is an acute disease that has long-term consequences in some patients, but it's not generally a chronic ongoing inflammatory process. And then in terms of current research, there are a couple of studies going on to look at better medications to cut down on the rate of aneurysm, even after IVIG treatment. As mentioned, about 5% of patients, even after IVIG, still develop aneurysm, and we would like to get that down to close to zero as possible. So there are some studies looking at other or adjunct therapies. Then there have been some relatively recent studies and interesting studies in mice looking at whether specific medications could prevent this remodeling of the vessels. So as I kind of demonstrated, this kind of process where you have the eventual sometimes occlusion of the blood vessel, there are medicines that can slow down this process if needed. But the difficulty with this question is sometimes you do need a little bit of remodeling to recreate a vessel. The question is how much should you get, and how can you, in those patients, slow down that process? So in mice, there have been some studies. And then finally, just to talk about my own research, was funded quite a long time now. I had a one-year grant for Vasculitis Foundation, and it was looking at a particular protein called follistatin-like 1 protein in Kawasaki disease. And so this is the initial study where we found that patients with aneurysms in Kawasaki disease had higher levels of this particular protein than patients with Kawasaki disease in the middle there who did not have aneurysms. And so the question was, what does this protein do in Kawasaki disease? Now, this is a protein that everybody has in their blood, and there's no, as far as we know, there aren't people who have none of this, because it's a very, very important protein, so you can't be born without this protein. So really, it's thinking more about what is this gene, what does this gene do? Is it something that could be blocked, cause a problem, or is it helpful? And so this is a cross-section of a mouth part, which just shows on the right a normal mouth part, and the red is the lining of the heart. The red here is the lining which shows where the protein is expressed, and on the left is a cross-section of a heart, and you can see all this extra red is the extra epithelial-1 that is expressed all over the heart. So it's not only in the blood that we see epithelial-1 after Kawasaki disease, but it's also expressed all over in the heart. And so when I looked at trying to block this protein, what we saw that was without this protein, mice who got a very high dose of an agent that causes them to develop a Kawasaki-like syndrome seem to have a decreased rate of survival. So it seemed to suggest protein was protective. And when we also looked at the hearts of these mice, we found too that mice who have this protein which is knocked out have higher levels of inflammation. So all of these graphs, the leftmost bar graph, all these points on the left of these three graphs show the increased number of blood cells in the knockout mice as opposed to the normal mice. And so it really telling us that this is a protective gene, a protective protein. When we did something very high tech, we took these little cross sections of the heart, and we actually dissolved them almost into cell suspension. So sort of every single one of these dots represents a little cell that we kind of dissolved and made in a kind of almost like a liquid form. And then we could tell which cell was which using a sophisticated genetic technique. And we then wanted to see what would happen, what is happening in our mice that don't have these genes turned on. And what we found is In many of the cells, and this is our gene that's knocked out, we should see that, and this is a very, very complicated chart, but basically what it tells us is there may be a gene, another gene, which has got a fancy name, EBTB16, that is related to FSCL1, and that without FSCL1, you get increases of these two inflammatory genes. And so it's telling us a little bit about the mechanism behind FSCL1. So there'll be next steps. But so this study was, initially something that had been a long set of work, and initially the initial results were not as interesting as they are now. But that's where we are today with the research. So that's the end of my section, and I will stop sharing my screen.